Okay, IHSS. I used to call this the most named pathologic condition on earth. Subaortic stenosis. It's got a ton of other names. Dynamic aortic stenosis, but this and idiopathic hypertrophic subaortic stenosis. That was the name I was always taught when I was a kid. So the thing about this is asymmetric left ventricular thickening that is septal predominant. And some of it goes a little into the anterior wall, but your standard for comparison is that lateral myocardium. Is the septum thicker than the lateral myocardium? Because that is unusual. So it's pretty striking, that septal thickening, and again, compare it to the lateral wall. And don't be bothered if a little of it does go out onto the anterior wall. And right there, in that immediate subaortic region, is where the obstruction happens. So when the septum thickens up with contraction right in that aortic outflow tract, that's where the dynamic obstruction of the aorta occurs. And it's actually probably worth just pausing it right there. I should have highlighted it, but right there, see how thick that septum is getting, right? And it's encroaching there into the subaortic outflow tract. So that's the source of the dynamic stenosis. And on this more coronal view, you can really compare the thickness of the septum to the lateral wall very nicely right there. All right, so that is IHSS, or whatever they're calling it these days. Okay, this one is one of my favorites. The residents, I showed this several years ago on our board review, and everyone just kept screaming restrictive pericarditis. To me, when I see extensively calcified pericardium, I was always taught to say histoplasmosis. I mean, it's just a knee-jerk reflex for me, because there's very little else that will cause this. If you can come up with a history of a previous hemopericardium, sometimes you can get mets to the pericardium that cause bleeding, specifically melanoma. But those are all pretty extreme circumstances, and they're not going to, I don't think, look like this, right? A nice smooth pericardium that's got all this almost curvilinear calcification to it. So this says to me histoplasmosis. So you can see that calcified pericardium. The beauty of this case is all the hemodynamics that it demonstrates. So look at the IVC. As a result of this restrictive pericarditis, this patient formed a little left ventricular aneurysm there at the apex in a place where there was a gap in the pericardial calcification. So it just went to an area of least resistance. The left ventricle was seeing more blood than it could handle in its restricted state. And so it popped out this little apical aneurysm. Look at this IVC and the coronary sinus draining into it. Those are all the cardiac veins, and they're just massively distended, right, because of the increased venous pressure resulting from restrictive pericarditis, sorry. So there is a huge IVC, big dilated cardiac veins and coronary sinus, and of course the liver is beginning to suffer as well. So there's the IVC and an enlarged liver that's starting to have an abnormal contour. There's a little perihepatic fluid suggesting early ascites. So the SVC is prominent, as you would expect, right? Restrictive pericarditis has a more pronounced effect on the right-sided circulation, right, with a backup into the venous return. And that's just because the right ventricle is weaker and more susceptible to restriction or compression. Right? And there's that little left apical aneurysm, big dilated IVC. I was disappointed there isn't more backflow into the hepatic veins, but I'm sure if we'd timed it just right, we could have caught that. There is a tiny wisp of it, actually, if you look closely. Oh, I needed to check the time. All right, we've got time for a couple more. Cool. Okay, a couple of coronary artery findings. Kawasaki's disease is easy. When you see calcified coronary aneurysms, there's not much of a differential on that. So that's nice that it's one of the more specific findings in radiology. So you can see that aneurysm. I mean, IV drug use, things like that can give you aneurysms in strange places. And so I suppose that is a way low down thing on the list of differential possibilities, but the vast majority of these had Kawasaki's disease at some point. In the acute phase, you won't necessarily see them calcify. So this one actually had involvement of the right coronary, which you can see is occluded here. And that is a risk with this disease. So nice 3D that shows that calcium. And then there's the right coronary cutoff. You can see there's a whole segment there that is occluded. All right, so you certainly can get you certainly can get coronary artery aneurysms from other things, and certainly the venous grafts in a bypass patient will develop them as well. But a calcified aneurysm in line with the vessel like that, that's going to be Kawasaki. So nice 3D depicting both of those, the calcified aneurysm walls and that segment of right coronary occlusion. I wouldn't hang my diagnosis on that image set alone, but it is kind of neat to see. All right, so this is one called a myobridge, and until I started reading coronary CTA, so I'd gone through internal medicine and worked as an ER doctor and all of that, and I had not heard of this. So when I started reading coronary CTA, though, my cardiology partner taught me about the myobridge. And so this is a cause of dynamic LAD obstruction. And it occurs when the heart contracts, there will be a segment of proximal LAD that is encircled in myocardium. It dives into the myocardium itself instead of lying on the surface like a good coronary artery should. And so it gets squeezed with each contraction. And what that results in is distal LAD territory ischemia. And I really like this case too because it shows the development of subendocardial fat as a result of a small infarct. Right? So this is just a non-STEMI, most likely, a subendocardial as opposed to transmural infarct. And what happens is that infarcted region will undergo fatty metaplasia, and there will be these little linear stripes in the myocardium, more on the endothelial side. And here is the LAD dropping into the myocardium and then popping back out. And of course, you'll see that better on the cine. But there is the LAD, and it's got a rim of myocardium on top of it, which should not be the case, right? It should be sitting on the myocardium. These can be tough to spot, and incredibly, I'm going to give it to the 3D that it shows it really nicely. You can see that that vessel is not on the surface of the myocardium. It's actually diving down into the meat of the left ventricle. So you can track it here. Right there is where it dove in, and then it pops out onto a normal location. The LAD, by the way, is always anterior to the interventricular septum. You know, people can have variant coronary anatomy, and sometimes it can get a little confusing. But if you want to identify the LAD, just find the septum and look at the vessel that's right on top of it on the anterior wall. And that's going to be your LAD. So this is just a great case in that it shows you that dive into the myocardium, and it shows you the effects on the distal LAD territory in that we have that tiny little bit of subendocardial fat, which depicts a remote infarct. Can get a little tricky down near the apex there because sometimes there's a little fat, a little epicardial fat that can confuse things. But we've been over and over this one, and I'm certain that that does represent an infarct. So there's the infarct in the apex, and there's a coronal view of that artery. It dives down. It looks like it's a volitional act on the part of the vessel, right? there. We're going backwards, of course, but it really dives down into that myocardium. And here is the surface view showing that segment. Terrific. So that is a myobridge with a distal apical subendocardial infarct.